All
Well,
right.
thank you all so much tonight for inviting us to be here. It's always a pleasure to work with ACOI and to talk to some of our younger members in the profession and those things. Joe Gimo, as Dr. Good had said, I'm a pulmonologist down in South Florida. I've been practicing here for 34 years and had a chance to do a lot of critical care. I do sleep medicine also, a small amount of internal medicine, but mostly I'm a consultant-based practice. I'm in private practice down here, and I go to a number of our local hospitals. Today, we're just going to try to focus on COPD and just talk a little bit about exacerbations and how to evaluate those patients. May I have the next slide, please? So COPD, just a general definition, increasing dyspnea, cough, sputum production. Uh, when you talk about exacerbations, we really talk about the degree of them and how they're managed. And they're either considered mild, moderate, or severe. The mild and moderate forms of these exacerbations are really managed as outpatient settings and generally with just incremental increases in their treatment plans. First of all, we do use inhalers and bronchodilators. When a more severe exacerbation, we start to add steroids and then plus or minus antibiotics. And the severe exacerbations generally require hospitalizations and other modalities. May I have the next slide, please? When we diagnose COPD, chronic bronchitis by definition is just productive cough for 3 months over a 2-year period. And also an acute exacerbation is any changes in the character, sputum, or volume of the cough and worsening dyspnea. And next slide, please. And some of the slides I've taken from the GOLD criteria. The GOLD criteria are the global criteria. They're considered a consensus statements. And so when you see a slide like this, that's where I had attributed from. And they really have a wonderful resource for you to look at regarding COPD and obstructive lung disease. And as you talk about evaluating a patient with COPD, the first thing is to do your clinical assessments, which I think that as an osteopathic internist and an osteopathic physician, you're really trained to do these things well. You evaluate the patient looking for concomitant diseases, talking about signs and symptoms, looking for other modalities, other problems that could cause it. And then when we assess the patient, we talk about the VAS, which is the visual acuity, how sick the patient looks, those types of things, documenting the presence of cough, and then looking at their vital signs. Most of the time, somebody with COPD, they're going to really tell you, like a lot of diagnoses, is how sick that they are. You're going to notice things if they're tachypnic or tachycardic, the changes in their volume of their sputum and the color of that, and use of accessory muscles of respiration, so-called tripoding, where they're leaning forward on the table or desk and trying to use those accessory muscles. Also, to evaluate the severity, we look at other objective findings too, such as our pulse oximetry, laboratory findings, and we'll get a chance to go through some of those, CRPs, arterial blood gases. And then once we get that lexicon of things together, you start to put the pieces and decide what level of care they need, and then establishing those intervals in care and establishing the event or what was the trigger that found and caused the etiology. Can I have the next slide, please? So when you're talking about an exacerbation, again, we're talking about changes in the character of sputum, increasing shortness of breath, increasing dyspnea. There's a wide differential that you see with that. So you're thinking about, could it be a pneumonia? Could it be a pneumothorax, collapsed lung, a pleural effusion, a pulmonary embolism certainly masquerades as so many things, and increasing dyspnea certainly would be that. Congestive heart failure or cardiac dysrhythmia, as we have our colleague Chris is going to go more into detail about the cardiac manifestations of some disease processes tonight, so you get a chance to talk to him also. The next slide, please. And when you see that, it really jumps into just a few categories of the things, the testing you want to do. Most of the time on all these patients who present with dyspnea, you're going to get a chest x-ray. That's first thing out of the gate, whether you're in a clinic or in the hospital setting, you're going to be able to take a look at that and see. But then for some of the other diagnoses, particularly a pulmonary embolism, you're going to start to look to other things. You're going to do a blood test for a D-dimer, which is elevated not only in people with problems with coagulation studies, but also in cancers and recent surgeries. So if somebody has a bone fracture or recent surgery, a D-dimer could be elevated, and it may not be from a pulmonary embolism. We have to do confirmatory tests with that. And some of the easiest things to do are Dopplers of the lower extremity. The majority of clots that we have for pulmonary embolism are going to come from the lower extremity. But a CT angiogram is really the definitive test for that, to take a look for a pulmonary embolism. Also, you can do a ventilation perfusion scan or those things, but they have more nuanced findings with them. A ventilation perfusion scan has ventilation where you inhale a gas and also the perfusion, and you try to match those together. But a lot of our patients with COPD have emphysematous disease, and I'll show you some slides of that in a little bit, that we're really going to mess up your VQ scan. So we tend to get away from that. And looking for congestive heart failure, we're looking for a proBNP, echocardiograms, and chest X-rays. Now, after those tests are done, what about some of the other stuff? We're talking about pneumothoraxes. We're taking a chest X-ray or an ultrasound of the chest can pick that up quite readily, and also talking about a myocardial infarction or cardiac dysrhythmias, EKGs, echocardiograms, and troponins. So next slide, please. So when we talk about treatment and you're looking at this patient, they come into your clinic, they come into your emergency room, they come into your setting, your practice setting. 80% of the time when you're seeing one of these patients, you're going to be able to treat them as an out person. And the things that are going to make you think that you need to put them in the hospital are going to be some of their vital signs. Tachypnea, rapid respiratory rate, worsening dyspnea, and if they've been on outpatient therapy already and failure to respond, those types of things make you think more towards more intensity of their treatment plan. Also looking at medical comorbidities, if they have a history of congestive heart failure, they're diabetic, they have sleep apnea, other things are going to be more likely that they're not going to do well outpatient. And then certainly if they have inadequate support at home. So if you have an elderly person who's not going to be able to get around and take care of themselves, a lot of times you lean more towards hospitalization than not. Next slide, please. So when you're managing those exacerbations, the first thing across the board is you're going to talk about short-acting bronchodilators and either beta-2 agonists, which work in the periphery receptors, or anticholinergic, which work on the central receptors. Each of them has great benefit to them. They can give in a combination too, where you can have them both together. They can be given as a meter dose inhaler, or they can be given as a nebulizer treatment. And then supplemental oxygen. Frequently, you're going to give them some oxygen where you're at and follow their pulse oximetry. Particularly if their oxygen level is less than 88%, they're going to require oxygen. When you do an ABG, you're going to see whether or not their CO2 is elevated. And if their CO2 is elevated, then you worry about things like them having a primary respiratory drive related to hypoxemia. And that's where you give them a Veni mask. A Venturi mask controls the amount of oxygen that comes in. So if somebody has a primary hypoxic drive, they're going to be less likely to slow their respirations when you abate that. You talk about ventilator support, smoking cessation, and reducing short-term mortality morbidity. And we find by doing that, giving antibiotics in a moderate to severe degree of exacerbation really helps improve that mortality morbidity. And it even decreases treatment failures by 53%. So as much as we talk about, on the next slide, please, as we talk about outpatient and inpatients, we talk about the triggers and the factors that affect this. Antibiotics early on are frequently given. So the mild to moderate patient, it's a bronchodilator, an oral steroid plus or minus an antibiotic, adequate home support, and stable status, and they're out the door. The next slide, please. Factors for inpatients, failure to respond to therapy, inability for the patient to be able to help themselves, the comorbidities. Next slide, please. And then talking about, well, what antibiotic do we want to do? We said if they're a moderate to severe patient, giving them an antibiotic is probably going to help them improve their mortality and morbidity. So the most common thing with this is viral infections, though. So antibiotics don't do very well against them, certainly at all. So you're looking at antivirals. Now we're fortunate that we have medications like Paxlovid and Tamiflu that can help treat those, and we can even identify a lot of the viral infections now with respiratory panels. I mean, down here in Florida, we tend to see things a little bit later in the year. People come from the Northeast, they come down here seasonally, and then so we'll start to see flu and influenza, and then after that we have a lot of COVID, RSV, parainfluenza, those things. But after they develop that first viral infection, frequently to a week to 2 weeks after that, to 10 days after that, they start to develop productive coughs and discolored sputum. And that's not viral anymore. That becomes bacterial because what happens is the initial infection decreases their immune system's ability to respond. So then they're susceptible, generally strep pneumonia, Haemophilus, parainfluenza, MCAT, and Pseudomonas in some individuals. If you're a diabetic, then you worry about Pseudomonas. If they have structural lung disease, you start to think about Pseudomonas when you start to pull out your antibiotics. So obtaining this respiratory viral profile is very helpful. And then also a blood test called procalcitonin level. If they're elevated, that's suggestive of a bacterial infection and makes you more prone to give them antibiotics. Now, the next slide, please. So an uncomplicated patient, a patient that you're going to talk about sending home, mild or moderate, this patient, you can give one of these antibiotics, Azithromax, amoxicillin, clavulanic acid, doxycycline. And all of them were looking at about 5 to 7 days of duration. In the past, we used to talk about 10 to 14 days, and we really don't like to go with antibiotics that long anymore. Next slide, please. If somebody's more complicated, and these are the patients with moderate to severe who you're going to probably admit, or they have other medical comorbidities, you're talking about a lot of the quinolones, and you're talking about Zosyn or Sevapenem. And these medications, you really want to get a decent sputum if you can beforehand, because you want to try to narrow it down. Those are folks that you're probably going to keep in the hospital at least 3 to 5 days. And with that course, you want to try to narrow their antibiotic selection as best as you can afterwards. Next slide, please. So now we have the symptoms, we have the treatments to go through, smoking cessation, bronchodilators on all of these patients. Next slide, please. Oh, there we go. So the moderate patients, we're adding the steroids and antibiotics. Next slide, please. And the severe patients, that's when you start to get the intensification of therapy. Then all these patients are on steroids. They're all on antibiotics. They're all on supplemental oxygen, and they're on nebulizer treatments. And then sometimes you have to talk about ventilators, or you talk about non-invasive ventilation like BiPAP machines and those things. Next slide, please. So just to start out with a case. So we have a 72-year-old male who comes in with shortness of breath over the last 7 days. He had a productive cough. He was seen by his primary physician and was started on azithromax as an outperson. He has a history of hypertension, high cholesterol, coronary disease. Surgical history, had an appendectomy and a PTCA about 7 years ago. He still smokes. He smokes a pack of cigarettes a day. His occupation is as a plumber. He takes a PRN inhaler, albuterol, and he takes blood pressure medications and a statin. Next slide, please. These are his vital signs. He's a little tachycardic with his pulse rate of 112. His respiratory rate is tachypneic. His blood pressure is a little elevated. He has an elevated temperature of 101. He's a little portly. He's 5'8", and he's 210 pounds. And his O2 sats are 89%. On physical exam, his pupils are echoreactive to light. His heart sounds are very distant. He has coarse rhonchi throughout, coarse breath sounds throughout his lungs. His abdomen is soft. There's no bruise or rebound. He has no clubbing and has good pulses, and neurologically he's intact. Can I have the next slide, please? So these are some of the laboratory data here that we're going to go through and talk about. And then I can certainly open up to questions. I have about 10 more slides after this that I can go through with other things. But if it's more helpful to you, we can ask some questions about it, how you would want to approach it, or I can go into how you would work this up. So I'll leave it up to the audience here. I know we have three folks here who might want to. Do you want to talk about how you would work this up first, and we can go through the differential, or do you want me to go through and go through how the workup is done? What's better for everybody? I don't know if we have
Let's go through it. Let's go through the workup so they can
get an idea.
A lot of progress involves with their board.
Okay, sure. So their hemoglobin is a little elevated. Their hematocrit is 15. Their platelet count is 381. Their white count is elevated. Excuse me, their platelet count is 443. Their white count is mildly elevated. They had not been on steroids prior to this. Their sodium is a little high at 145. Their bicarbonate is elevated at 42, and their BUN and creatinine are slightly elevated. So that's telling you that they're probably at least intravascularly dry. In other words, they're a little dehydrated. And it's also showing that with their bicarbonate being up that high, there's probably some other things going on. And that's when we look at the ABG. And the ABG shows that they have a pH of 7.45. Their CO2 is 46, which is elevated. And their PO2 is depressed at 54. So we're seeing that they don't have a metabolic alkalosis here. Their bicarb is 42. So that's probably telling us that they're blowing their CO2 down a little bit more than they usually would. Their CO2, even though it's elevated here at 56, is probably in the mid 60s on an average day for them because their pH is elevated here. So they're hyperventilating. You take a look at their chest x-ray and they're hyperinflated, means the lungs are fully expanded, the diaphragms are flattened. And on their CT scan, it shows emphysema emboli. Can I have the next slide, please? So this is what their chest x-ray would look like. When you see that, you see the anterior ribs, you can see them and count them all the way down. You see the diaphragm are flattened down at the bases. And you see on the lateral view of the chest, you see the retrosternal airspace is more prominent. So you can see that. And that's what you see. It's a long linear chest of somebody with emphysematous disease. And the next slide, please. Now, this is the CAT scan for them. And you can see that it's a bit of a mess. They have a lot of heterogeneous pattern here. They have a lot of bulla, which are large air sacs. I always like to tell the patients their lungs are like sacks of grapes. They should look that way. The alveoli should look small grape-like structures, and the stems of the grape are the interstitium. And what happens is you develop emphysema, those small grape-like sacs develop into these large bulla. And these they don't exchange gas very well with these large air sacs. Next slide, please. You look at their vital signs, and what is going to determine when we saw that patient, what are the things that we want to worry about most? And the pulse oximetry is the most predictive value on that patient on whether or not they're going to have a problem or not. So their pulse ox was low. The next thing you do is you look at their respiratory rate. Now, when you get out in your clinics, everybody has a respiratory rate of 20 when they write them down, but that's really tachypnic, really. Over a rate of 25 is significantly abnormal. And if their rate is over 30, that is somebody you're more concerned about. The reason for that is that they're breathing so fast, their work of breathing is going to tire them out. And especially when you see somebody with COPD, you see that big hyperaerated chest. Their diaphragm, which is the muscle that does most of the work, a primary muscle respiration, works as a piston going in and out of the chest like this. But when the diaphragm is flattened like this, it can't move back and forth and move the lungs back and forth. So when you get a hyperinflated chest and somebody's tachycardic and tachypnic, they're not a very efficient person, and they're going to have more problems with that. We look at their pulse rate when their pulse rate's elevated. So those three findings are really important when you're looking at that patient for COPD or respiratory distress. If you see they're elevated, you want to be more concerned about them. Next slide, please. So what are the testing we can do? Certainly, echocardiograms are great. With an echo, you can look at that. It's not only going to tell us whether or not they have any valvular dysfunction or signs of cardiomyopathy or those things, but also we're going to look for pulmonary hypertension. And that'll be the right ventricle will be elevated, and we'll see those pressure elevated. That could be another cause for the dyspnea. The elevated D-dimers, I said before, surgery, cancer, and DVTs can all cause that. And then we look at the pro-BNP, the ventilation perfusion scan with the caveat that it does have some limitations, the CT angiogram, a thyroid panel to look at that. I always like to look at their phosphate and their magnesium because you'll find a lot of people, they become somewhat malnourished, especially as they get a little bit older. They're not eating a balanced diet. You know, if they're hypomagnesiemic or their phosphate levels are low, that can cause some problems with respiratory issues. And certainly replacing those along with their other electrolytes is helpful. Chest x-ray, CT scans, when they're getting out of the hospital, when they're getting out of your clinic, following up those things, getting people involved with pulmonary rehab, vaccinations, doing a 6-minute walk, the 6MW, is a really nice predictive value test because what it does is you have a patient walk for 6 minutes as far as or as fast as they can go, and you measure their Borg score, their dyspnea score, and their heart rate and their oxygen level. It's a nice assessment of their cardiovascular fitness, and it's easy to do. You just measure it out in your office, how many times they walk back and forth. And then doing an overnight pulse oximetry, because frequently these people will have concomitant issues. They'll have sleep apnea or other things like that. And nocturnal desaturations are significant and increases the risk of them going to atrial fibrillation, cardiac events, and certainly neurologic events. Next slide, please. So monitoring the patient, oxygen therapy, maintenance inhalers, weaning their steroids. You don't want to keep people on steroids long term. A lot of people get to like to be on the steroids because it makes them feel better, but long term there's a higher incidence of cardiovascular events and other issues, so you want to get them off. Pulmonary rehab, vaccinations, and the Bode score, which is an assessment of their body mass, airflow obstruction, dyspnea, and exercise. Elevated Bode scores are not a good thing to have, and usually those are things you want to monitor. Follow next slide, please. The role of pulmonary function testing. You never really do PFTs when they're sick. You want to give them about 4 to 6 weeks after they got over their acute illness, because then you're going to get a more demonstrative thing about where they are clinically. And you're looking for that for diagnosis, and certainly you can rule things in and rule things out with it, but also for the degree of obstruction, how they're responding to therapies, and alternative diagnoses. So if you have somebody who's markedly dyspneic, at one of the hospitals I'm at, well, actually both of my hospitals, we do a lot of hearts, we do a lot of valves and stuff like that. We do them on an older individual, and you'll have a patient who goes through a bypass surgery, and when they're done that, and all of a sudden they're saying they're still dyspneic, and you find out that they have significant underlying lung disease also. So you want to look at both sides of it. The joke always with us is that, if you ask the pulmonologist to see somebody with shortness of breath, they're going to say it's a cardiac problem. You ask the cardiologist, they're going to say it's a lung problem. And so it's important to have that good duality of looking both ways with this. Next slide, please. When you talk about looking at a PFT, there's only a few numbers you have to look at. You can do a fellowship and all kinds of stuff with it and learn a lot about pulmonary function and those things. But as an internist, as a generalist, there's only a few tests that you need to get out of that. You want to look at the FEV1 to FVC ratio, and if it's less than 70%, it means they have an obstruction. And the next number you look at is the FEV1. And if it's greater than 80%, then it's mild, and then subsequently moderate, severe, and very severe, as listed on the slide. And then you look at the response to bronchodilators. And if you do have complete lung functions, it's good to see if they have a restrictive disease or the DLCO is their diffusion capacity. So if you see somebody who has small lungs and a low diffusion capacity, it makes you think more of an interstitial process, where if they have small lungs, the low lung volumes, but the diffusion capacity is normal, you start to think of other things, perhaps chest wall abnormalities, a pleural effusion, or some kind of restrictive disease, ankylosing spondylitis, or scoliosis could cause these problems. Next slide, please. And when you look at a PFT, you look at the flow volume loop. The top left one is a normal configuration. And you can see the top right one is just restrictive disease. So it's just like a mini-me. It's a smaller version of the same thing, but they're not getting the same lung volumes, but there's no obstruction. The next slide down on the left is an obstructive pattern, like a shoehorn pattern. So they get a little bit of air out and there's a slow gradation. Remember those big air sacs that we saw before? Not all the alveoli are emptying at the same time. So you have these big air sacs that are slowly letting the air out. So that's where there's a prolonged expiratory phase. And then looking at the flow volume loop also tells you some other things and gives you a hint about obstructive processes. If you see it's cut off in both the inspiratory limb and the expiratory limb, the top and bottom limb, that's showing that there's some fixed airway obstruction, like a tracheal stenosis or something like that. If you see an extra thoracic variation, then you're thinking of something above the cords. If you see an intrathoracic or variable obstruction, you're thinking it's below the cords. So it sort of helps give you some ideas of what you're hunting for. Next slide, please. And then starting to look at this, it's nice when you're out in practice, you start to look at patients and say, well, I think they're sick, I think they're not sick, but these are the kind of things that they've created different parameters to help gauge things for you, to make it more of an algorithmic thing. And one of them is this modified MRC score. And it's just assessment of how short of breath somebody is with exercise. So a grade 0 means that they can exercise and walk and do whatever they want without any dyspnea. And 1 is some shortness of breath on a small level hill. 2 is while they're walking with people of their same age. 3 is when they're walking 100 meters. And 4 is they're breathless, just dressing. So you see, with that level, that gives you one number. So then we're going to see the next slide, please. And you see that, then we take that first number, and then this is a second scoring criteria, the CAT score. And this is just a few simple questions, and you answer these questions and you grade those all up. And it's like, am I coughing? Am I having chest pain or shortness of breath walking on flight? So there are two different types of tests, but you take these two numbers and these scores. Now go to the next slide. And then you combine them in the gold criteria that I was talking about before. So you're trying to grade that. So you take the pulmonary function test that you see in the middle here. The middle slide says grade gold criteria 1, 2, 3, 4. That's how severe the obstruction is by the FEV1. And you take that and put it with the grading system at the bottom where it says symptoms on the right, where it says the MRC score and CAT scores. And they fall into one of these three categories, A, B, and E. A is the least severe. B is a slightly more severe, and E is the most severe. And on the left-hand side, you see they combine it with the number of exacerbations they have a year. When you put them in that lexicon, then we go to the next slide. And then you see from that, you start to talk about how you want to treat them. So you talk initially, you're going in the FEV1, you're looking at that and seeing their criteria. You're doing the CAT and the MRC scores, and that's that gold ABE scores, their exacerbation, their smoking status. And then looking at blood work on them in this eosinophil level is something that you're going to see. They're going to talk about that and say, was this a patient who is going to be able to respond? Is this somebody you want to give inhaled steroids to? And we'll go into the next slide now, please. Talking about in those first categories, you're talking about a long-acting bronchodilator and a long-acting muscarinic. Those are the more severe patients. So you're giving long-acting medications. And you see if it says if the eosinophil level is greater than 300, then steroids are going to be more effective with that patient. Whereas in the other categories, you're not really talking about giving steroids that much. And next slide, please. once we talk about giving people inhalers, there's a number of criteria we use to decide what's going to be best for them. Powdered inhalers, meter dose inhalers, there's a number of different combinations that are out there. Generally, patients, the less medicines you give them, the better, the more compliant they'll be. So once a day medicines are generally better than twice a day. And sometimes, depending on the device, like powdered inhalers are very difficult for people to inspire to. There's medicines called like Brio and Trilogy. They're good medicines, but they're powder inhalers. So somebody has to have a certain amount of inspiratory force to get the gas in. Those patients, you might want to do a container inhaler, a meter dose inhaler that's going to spray the inhaler in. So those are some factors. Also, a patient's ability, maybe if they have problems with their hands or their joints, they're unable to manipulate an inhaler. And those things, sometimes you might want to use a nebulizer treatment. So when you're looking at the patient, it's not just picking the right medicine, but the delivery system is also important about how you want to approach them. And next slide, please. And this is an interesting slide. I think you'll see more and more of this now because we talk about this. It's pretty commonplace in all the literature about whether or not you put somebody on a steroid or not. And this is the kind of thing that people like to test you on. So if you have a patient and they come in and they're having an exacerbation and you do a blood test on them and they have an elevated eosinophil count, they're going to be a patient that's going to be more likely to respond to an inhaled steroid. So you want to do that. At the other extreme, if a patient is coming in with recurrent pneumonias and their eosinophil count is less than 100, they're probably not going to be responding to steroids as well. And matter of fact, inhaled steroids will increase the risk of them developing a lower respiratory tract infection. So you try to look at the two ends of the spectrum there. And next slide, please. And so we go through cycles and evaluating the patient. Next slide. I'm going to get to the end of this. Talk about vaccinations for patients. Next slide. And then we talk about oxygen therapy. And generally, oxygen therapy is one of the few things that we do that really helps improve patients' long-term survivability. There was a study called the KNOT study. It was done a number of years ago. If people need oxygen and they're using it for over 15 hours a day, their long-term survivability is better and improves quality of life. Next slide, please. And then we talk about who needs oxygen. If your oxygen level is less than an arterial blood gas of 55 or their SATs are less than 88%, they need oxygen. You prescribe it for them and then you reassess them in 60 to 90 days. Next slide, please. And then we talk about other things. Some things are not good for people with COPD. Opioids are not good for COPD patients. Antitussives are generally not as considered good for patients because you're suppressing their cough. Next slide, please. And then we talk about the classifications, mild, moderate, severe. This is sort of a summation slide for the clinical findings for you to have. Next slide. And then hospitalizations, talking about severity of symptoms, onsets, presence of comorbidities. Next slide. And then managing the patient as outpatient for these life-threatening things, talking about some of the things that they can do. Next slide, please. And non-invasive ventilation. And that's sort of where I can sort of finalize it here. When the patients are that sick, you're really talking about putting them on a non-invasive ventilator. They're basically ASV machines and an automated systemic ventilation, or they're talking about a BiPAP device. And what it does is that helps decrease that work of breathing for a patient. So those are patients who are not responding to therapy. When their pHs are down, they become they're showing signs of respiratory muscle fatigue, and they're having persistent hypoxemia. And next slide. That should be just about to the end. And if they're unable to tolerate the non-invasive ventilator, then you put them on a ventilator. You intubate them and put them on a ventilator. And if they're hypercapnic or having significant cardiac instability, that you put them on a vent. Next slide. And the discharge criteria, the follow-up. And next slide. I know I'm running out of time. I don't want to take my colleagues' time too much. And this is just a simple thing that you can have in your clinic for follow-up evaluation. So thank you very much for your time. And